Good afternoon, everyone, and welcome to the Lynn Cancer Institute updates. As always, we're trying to keep you in the know in 2024. We're so grateful that you all joined us today for a presentation from our survivorship series. Today, Dr. Richter will be presenting the late effects of radiation therapy. Our survivorship education series is offered to patients who are currently undergoing treatment, as well as those patients who have completed their treatment. We always like to include their caregivers and our oncology staff as well. We all enjoy being educated. In the interest of time, Dr. Richter's bio was sent to you by email. And since you will be muted, we ask you to take notes during his presentation. And if you have a question, you can put it in the chat box or the Q&A box, and there'll be time at the end of his presentation for Dr. Richter to address any questions that you might have. So that being said, we're very proud to welcome you and to introduce Dr. Samuel Richter. Dr. Richter?
Thank you, Jan, and happy Friday, everyone. I'm Dr. Sam Richter. I work in the Department of Radiation Oncology at the Lynn Cancer Institute, and I'll be speaking to you today about the late effects of radiation therapy. I have no disclosures or conflicts of interest to report, other than I'm a radiation oncologist. Today, we'll talk a little bit about what radiation therapy is. We'll review the late side effects of radiation by organ system, touching on the skin, cardiovascular system, lungs, GI tract, as well as central nervous system. We'll review strategies, technologies, and techniques that we employ here at LCI to help minimize those late effects. Radiation therapy is often thought of as a scary treatment, something to be avoided. But harnessing that power of treatment and utilizing it safely and conformally can allow significant therapeutic benefit. Like I tell all my patients, there's no free lunch. Any doctor who tells you there's a 100% chance of cure and 0% risk of side effects and nothing's going to happen, it's probably not giving you the whole story. It's important to note that side effects of therapy, which we'll talk about, are possible, but not necessarily expected with treatment or experienced by all patients. Every patient's different, unique, and may actually have inherent sensitivities to treatment itself. As a radiation oncologist, I'm often tasked with balancing the need to treat the cancer now, at present, something that could be growing, but also taking into consideration the risks of treatment, both during therapy as well as deep into the future. Today, we'll talk about some of those future risks, late side effects of treatment, and ways to minimize them. So what is the biological basis for radiation? Radiation works by damaging DNA of cells, destroying their ability to reproduce. Both normal and cancer cells can be affected by radiation, but cancer cells generally have the impaired ability to repair this damage. This leads to cell death. Healthy tissues know what to do with that radiation damage, and all tissues have a tolerance level or maximum dose beyond which irreparable damage can occur. This can result in either delayed or more chronic late side effects. Function of radiation is really twofold. One, in some situations, to cure cancer, destroy or ablate tumors that haven't spread when things remain localized or early stage, or to kill residual microscopic disease left after surgery or chemotherapy. In other situations, it's simply to palliate symptoms, to shrink tumors affecting quality of life, such as a lung tumor, which could be blocking the airway, causing obstruction or shortness of breath, as well as to alleviate pain or sometimes neurologic symptoms caused by tumor that's growing or expanding, as in the case sometimes of bone metastases, or in the case of sometimes spinal cord compression, as you see on the right, where a tumor is getting into the spinal canal, putting somebody at risk for myelopathy or paralysis. As far as radiation therapy effects are concerned, there are early effects and late effects. Early effects are those during radiation therapy, leading up to 3 months thereafter, which generally result from death of a large number of cells occurring within a few days or weeks of irradiation of tissue with rapid turnover. These damages, these effects can be repaired rapidly because of the rapid proliferation of stem cells and can be reversible. Late effects appear after a delay of months or years and occur predominantly in slower proliferating tissues, lungs, kidney, heart, liver, central nervous system. They can improve, but sometimes they're never completely repaired. Late effects depend on which tissues or parts of the body are being treated. Location's everything. what volume of tissue is being treated, the dose of radiation received, whether that's the daily dose, the frequency of its treatment, or the total dose over the course of therapy, as well as other treatments which may be given at the same time, before or even after, such as chemotherapy, as well as sometimes even surgery. Often the line between an acute effect and a late effect can be blurred. Side effects by system, we'll go through the skin, cardiovascular system, lungs, GI tract, as well as CNS. And as far as the skin, late effects we see on the skin, fibrosis, sometimes telangiectasia or squiggly blood vessels, radiation recall, atrophy or shrinkage, sometimes cell death or necrosis in nearby tissues, as well as more rarely a secondary skin cancer, just by the fact that some of this healthy tissue of the skin had seen radiation therapy. What you see here is a chart from UpToDate, showing sort of a common progression of radiation dermatitis, which we expect more acutely with treatment. On the left in panels A and E, the top panel being a patient with fair skin, the bottom being a patient with darker skin. I would say that panels D and H represent very rare and unusual skin toxicity from radiation therapy. Often patients think of this when they think about radiation as it's being delivered in the case, let's say, of breast cancer to the skin. I would say that these days with conformal techniques, these are uncommon, but having a severe acute reaction can result in a delayed effect such as fibrosis. As far as fibrosis is concerned, it's commonly seen in breast cancer patients. The risk is often low, particularly with the use of more modern skin-sparing radiation equipment as well as techniques. Signs and symptoms, skin retraction, induration, loss of elasticity or plasticity of skin, shrinkage, and sometimes limited joint mobility or lymphedema. How do we prevent this in certain cases? Well, it's the technique. In cases of breast cancer, we have skin-sparing intensity modulated radiation therapy, which is a way of delivering advanced conformal radiation that changes the intensity in different parts of a single radiation beam. This allows the treatment to be more sculpted. We can vary the intensity even within a single beam, and often allows us to dose paint or deliver radiation in a way where some tissues get higher doses, meaning the target where we want it to go, while other doses might get significantly lower doses. This also results in a more even dose distribution where there are less hot spots and thus potential less skin toxicity. Another way to limit radiation skin toxicity, at least late effects such as fibrosis, is to not treat the entire breast, to treat part of the breast instead of the whole breast, and we'll get into that in a little bit. Ways to treat fibrosis, pentoxiflin, as well as vitamin E, have been studied and are sometimes indicated in select cases. And of the two treatment plans you see here, we have an example of a skin-sparing IMRT technique in a patient who's having her breast as well as lymph nodes treated. And on the bottom panel, a patient who's just having part of the breast treated with radiation. The woman in the top panel is getting treated over about 3 weeks, while the one on the bottom over just 1 week. If you can spare most of her breast, and in both women, you're actually sparing a lot of their implants, both these women have augmentation, you also improve skin toxicity as well as limit the risk for any capsular contracture or impact on their breast augmentation. As far as the skin's concerned, another late effect, a radiation recall reaction, can present as a dry rash, some desquamation, itchiness, ulceration, can affect more than just the skin, can affect mucosa of the lung, the oral tract as well. Generally, this is self-limited, generally resolves by eliminating any drugs which may have been given after radiation. It's similarly managed like dermatitis with creams, lotions, and obviously withdrawal of another medication that can happen when things are given either concurrently or sequentially. Common agents like chemotherapy, targeted agents like some of the more EGFR inhibitors or immunotherapy drugs can precipitate a reaction like this of the skin. As far as what we encourage patients to use in radiation therapy to try to limit acute effects from radiation on the skin, good old Aquaphor. We give samples when patients come in, pure aloe, mixtures of medications and salves with calendula. And sometimes we need to bring out more prescription medications like steroids or Silvadene cream in the case of more significant skin reactions. As far as the heart's concerned, any component of the heart can be affected by radiation. Late effects of radiation to the heart include chronic pericardial disease, coronary artery disease, cardiomyopathy, valvular disease, as well as conduction abnormalities. Treatment-related factors include that of total dose of radiation delivered, dose per fraction, the volume of the heart seeing the radiation, as well as the concurrent administration or sequential administration of chemotherapy and a particular medication called trastuzumab or Herceptin in the case of HER2-positive breast cancer. Patient-related risk factors, those that are younger age, who are likely to live much longer, can see the secondary effects of radiation. Presence of other risk factors, including coronary artery disease to start with, high blood pressure, smoking, and obesity can predispose someone to have even more of a effect from their radiotherapy. Exposure of the heart to radiation increases the rate of ischemic disease. We know this. The increase is proportional to the mean dose of radiation to the heart. Women with pre-existing risk factors have a greater risk, a greater increase in risk and absolute risk of having some heart complication as a result of the radiation. It's estimated that 7.4% increase in the rate of major coronary event is seen for every 1 gray of radiation received by the heart. So the name of the game then becomes, how do we decrease the dose of radiation to the heart as much as possible? And the ways we do that, we have a number of techniques, particularly for breast cancer patients, is to do something called deep inspiratory breath hold, which we'll talk about, prone positioning, partial breast treatment, and proton therapy. In the case of deep inspiratory breath hold, we have one technique which we commonly use here at LCI, particularly for patients with left-sided breast cancer, since the heart sits more on the left side of the body. Patients can be coached or instructed on their breathing during treatment in real time. They can have video-assisted goggles or lights in the treatment room, which can give them biofeedback as to when their breathing is in the best position or the optimal range for their actual radiation therapy. Only when they're in that position, holding their breath for a couple seconds, does the radiation beam actually go on and deliver treatment. And as you can see from the slide, if this is the path of the radiation beam treating all of this breast tissue as a target, in this scenario, the heart's sitting right up against the chest wall. It's sitting right near where you want it to go. But if you ask a patient to hold their breath for a few seconds during therapy, the heart gets farther out of the way, it's pulled down and out, and less of it is touching the heart. Similarly, your lung is more expanded as the diaphragm's pulled down, so you're actually treating a lower volume of lung tissue. Less lung is being exposed to treatment with this technique as well. Another method to decrease dose to both the heart and as well as the lungs is to treat the patient in the prone position on their belly, much like a massage board. If you've ever gotten a massage, your face is on a pad, except this time, the affected breast in the case of breast cancer is falling away from the chest, using gravity to pull the breast farther away from the heart, farther away from the lungs, so less of it is being exposed to radiotherapy. This is great for women with larger breasts, excuse me, those with more anteriorly located breast tissue or tumor cavities. This can improve the evenness of the dose distribution, and like we said, can lower the lung dose as well. This is an example of what a patient's position might look like when she comes in for treatment. You can see here that the breast falls through the board where the patient's laying down. This is an example of one of the boards we have, sort of a cutout. The breast isn't touching anything, it's not resting anything, but it allows us to come from underneath and deliver the treatment so it's only glancing over the chest and not actually going through it. Another technique to limit dose to the heart as well as the lungs and be more conformal overall in treatment delivery is accelerated partial breast radiation. For carefully selected women with early stage breast cancer with favorable tumor biology and patient characteristics, APBI, or accelerated partial breast irradiation, is a method of treatment that can spare not only the deeper tissues at risk, like the lung and the heart, but actually limits the dose to the overall breast tissue. Because the majority of local recurrences of breast cancer occur in close proximity to the tumor bed, this technique allows for the delivery of larger doses per treatment, more conformally within about 2 centimeters of the actual surgery. This allows for treatment completion actually in just as little as 1 week. At our center, we've moved to treating women with APBI in just 5 days, 5 business days. At LCI, we've been actively pioneering a technique using our CyberKnife system to deliver that treatment in 5 sessions. Some patients are candidates for the CyberKnife for this type of protocol, but in reality, all of our centers, Boca, Delray Beach, Boynton Beach, all patients who qualify pathologically and in terms of their anatomy can potentially get treated with APBI at any of our centers. In the treatment photo you see here, this is an example of a patient, again, with breast augmentation. She had a small early stage invasive breast cancer, which was sitting on the other side of her implant in front of the pectoralis muscle. And instead of going through and through her implant, instead of touching more of her heart, which is over here, these color lines actually represent radiation dose. This machine, called the CyberKnife, can get the radiation in from different angles, non-coplanar beams, all adding up the radiation therapy right to where you want it to go. In this case, it's practically in front of the implant, away from the heart, sparing more of her lung tissue and a majority of her breast and implant. And again, another technique to spare the heart. What about the GI system? Bowel, rectum, late effects of the GI system, chronic diarrhea, malabsorption, obstruction, telangiectasia, ulceration, bleeding. These are the less common side effects, but real and serious ones in cases of patients where anyone is treating with radiation therapy near bowel, intestine, or rectal tissue, and even the esophagus. Prostate cancer patients, bladder cancer patients, gynecological cancer patients, anal cancer, rectal, stomach, liver, pancreas, all of these types of cancers need to take bowel dose into consideration. This is an example of various treatment strategies for patients with prostate cancer, whether it's more traditional 3D conformal radiation, IMRT, different types of proton therapy, or even brachytherapy, where you may have heard we can put actual radiation pellets into the prostate. In all of these scenarios, since the rectum sits behind the prostate, just behind it, there's really no way to avoid getting some dose to the rectum. The name of the game is how to limit it as much as possible. One technique that we have and is used at many centers is to put actually a rectal spacer, usually a gel, a hydrogel, between the prostate and the rectum, creating more of a bumper or a buffer so that less dose is actually touching the rectum. As you can see in this illustration, through an injection in the perineum, this gel, which is naturally absorbed by the body several months after the radiation is complete, can actually push the rectal tissue farther away from the prostate, so that the high doses of radiation therapy, as you're treating this prostate gland, you actually have this gel in there that creates a quote unquote space between the rectum and the prostate. This allows us to not only protect the rectum better, but allows us to increase the doses to the prostate and potentially improve outcomes from prostate cancer. You can see on the bottom panels are some MRIs illustrating the prostate gland. You see the injection, this whitish material that's actually creating a space and a bumper so that when the radiation is delivered to the prostate, there's less risk of rectal toxicity. By doing this now up front, before a patient's treated, and having this in throughout treatment can potentially limit any late effects on the rectal mucosa and reduce potential late side effects. We also have excellent technology at LCI, as many of you know, and we have a recently added weapon in the arsenal to help us spare bowel as well as other organs at risk when treating cancer. And I'm happy to report that this weapon is called the Meridian. It's an MRI linear accelerator. The radiation delivery of the MR-Linac is fully integrated with MRI. It's giving us another imaging modality in which treatment can be delivered and cancer can be monitored in real time as it's being given. The unique combination of technology, both a radiation machine and an MRI machine, allows us treating physicians greater control over the treatment because we can actually see exactly what we're doing in real time. As tumors and certain cancers move, depending on where they are in the body, this also gives us the ability to track them and being even that much more conformal. This ensures treatment fidelity, making sure we're hitting the right spot and what we prescribed is actually being delivered. It allows for adaptive planning. Let's say something moves. Let's say the person's a little gassy on one particular day. Let's say something changes over an entire treatment course. We can actually adapt the treatment and recalculate dose so that we're limiting exposure of healthy tissues to treatment. Also allows for the visualization and gating of entire treatment. So in the case, as it is in this lovely 86-year-old we had, there was a bulky cancer sitting just behind her diaphragm. She had exhausted options in terms of systemic therapy. She had essentially a lung cancer that had developed just at the base of the lung, tucked behind the liver and the diaphragm. And obviously it's in a challenging location. Our team made a decision to treat her growing lesion with just 5 treatments on this MRI linear accelerator on this platform. And the machine was able to actually track this tumor as she breathes. As you can imagine, as you breathe, we're not going to ask you to hold your breath for the entire treatment. The cancer and the tumor can move. So you want to hit your target, and this machine allows us to do so. This is an example of how her cancer had looked before her treatment. This is looking at it straight on. This is looking at it in cross section. And as you can see, just 6 to 8 weeks after treatment, she had a significant shrinkage and reduction in her cancer. On a different machine that wouldn't be able to actually track her tumor, you would have to add margin or extra amounts of radiation to make sure that you were covering the entirety of her tumor. So we're lucky to have this machine. We're lucky to have this technology. And for, let's say, in the cases of lung cancer, this has really afforded us an ability to see exactly what we're treating, adapt treatment, and make sure we're limiting dose to critical structures. Here's another example of a patient with a spot in their liver, a liver cancer, which is sitting next to intestine, bowel, stomach. It's a tough spot to treat classically, especially to high dose or therapeutic doses. And this machine, particularly for GI cancers of the pancreas, the liver, has really opened up new avenues and ways for us to treat and affect outcomes, and limiting toxicity both acutely and lately. As far as the lungs are concerned, radiation-induced lung injury has different phases. There's the immediate phase, the latent phase, the acute exudative phase, also when radiation, quote unquote, pneumonitis sets in, the intermediate phase, and fibrosis, which is a phase that happens as early as 6 months and can progress over years after receiving radiation to the lung. Risk factors for radiation-induced lung injury include the volume of lung treated, the dose of radiation, you've heard this before, the frequency of treatment, as well as the method of delivery, of which there are various options. Systemic therapy, chemotherapy, and immunotherapy, when that's given, whether before, after, or during, and then all the patient-specific factors, smoking, COPD, and baseline interstitial lung disease. Radiation-induced pulmonary fibrosis, the late effect, there really aren't established guidelines for its management. Unlike the acute effects of radiation on the lung, we tend to avoid steroids. It's important to implement supportive care in patients who develop this, such as oxygen supplementation, pulmonary rehab, etc. Patients following up with their pulmonologists, maybe getting respiratory therapy involved. But of course, often you have to treat the cancer, right? And many patients in our community can't go for surgery and ultimately need radiation as their curative modality. What's the best option here? It's really prevention, as it is for the heart, as it was for the skin. It's limiting radiation dose and volume of healthy tissue being exposed. Not unlike the partial breast radiation, we have a very conformal technique in terms of early stage lung cancer, or even in cases where there's limited progression of metastatic lung cancer, in which we can deliver something called stereotactic body radiation therapy, also called SBRT or SABR, ablative radiation. One strategy, again, is to limit overall exposure of healthy lung tissue to radiation. And by doing so, we limit the effects, both acute and late of treatment. This is an example of a patient who had about a 3.5 centimeter lung cancer, early stage. She did not want surgery. She didn't want to lose part of her lung, and she had already compromised breathing from having smoked in the past. This was a look at her lung cancer before it was treated. These colored lines represent radiation dose. These blue lines represent how the radiation is coming in from different angles, very conformally, very sculpted, to treat her cancer. Again, her case sitting on top of the diaphragm and on top of the liver, so something that needs to be tracked as she breathes. And we were able to successfully treat her on our CyberKnife system, which also has the ability to track the tumor as we're treating her. And this is about 1.5 years after her treatment. This is before treatment, this is after, and it really looks like that cancer has been annihilated. I think she's doing well. As far as the brain, late effects of any radiation to the brain include radionecrosis, neurocognitive decline, cataracts, stroke-like symptoms, unfortunately, optic neuropathy, dryness of the eyes, retinopathy, hearing changes. It can affect the endocrine system by virtue of where the pituitary gland is, as well as potentially secondary malignancies of particular concern in very young patients. neurocognition, impacted by something called whole brain radiation, which is how we used to traditionally treat metastatic disease once it got to the brain, and we still do in very select cases. Neuroregenerative stem cells within the hippocampus are radiosensitive and are important for cognition. So people smarter than me ask, well, what if we don't treat the whole brain? What if we treat just part of the brain, or at least if we have to treat the whole brain, why don't we spare the part of the brain that's most responsible for memory decline, that's most responsible for our cognition and higher level thinking? However, sometimes you do need to treat the whole brain. And this is an example of a patient, unfortunately, whose brain was littered with a number of different little spots, each of these representing metastases. Whole brain radiation therapy works. This is actually her after scan 2 months after. And all of these little dots, all of these little spots, these metastases had melted away. They went away. But there's a cost to be paid, right? Even though the cancer's controlled, even though this went away, she is still a setup for late cognitive change. So we have something called hippocampal sparing radiotherapy, which has now been well studied on clinical trials, and that we've learned that by sparing the memory center or the hippocampus, you can actually improve neurocognition, memory, recall, higher level executive functioning, 6 months after a patient's been treated. Each treatment to the brain is obviously individualized. Not only can we have sparing of the hippocampus called hippocampal avoidance radiation, but there is drug therapy that can help patients after their treatment. Things like Provigil, Ritalin, sort of wake promoting or stimulating agents can make patients perk up. Things like memantine or Namenda, an NMDA antagonist, sometimes used for mild cognitive impairment or Alzheimer's, can actually significantly reduce the risk of cognitive toxicity, particularly in patients that get whole brain radiation. This drug has been shown to improve executive functioning, processing speed, as well as delayed recognition. Just like the other treatment strategies in other parts of the body, well, what if you don't treat the whole brain? Are there select cases in which you can treat just part of the brain? And just like stereotactic body radiation, we have stereotactic radiosurgery, where we can be more pinpoint and precise and conformal in our treatment of maybe select few metastases in the brain. There are cases now in which we're doing this for up to 15 or 20 individual spots in the brain. For patients who develop metastatic brain lesions, SRS or stereotactic radiosurgery is commonly delivered in a single treatment, a one-day treatment of maybe no more than 30 minutes. At the Lynn Cancer Institute, we use something called the CyberKnife. You may have heard of other facilities using something called the Gamma Knife, essentially effectively doing the same thing. Sparing healthy brain tissue is particularly important in our community, in Boca Raton and South Palm Beach County, where there's an overwhelming majority of patients tending to be a bit older, already with some baseline cognitive decline, maybe some who've already had systemic therapy or chemotherapy that's knocked them down a notch. So the more healthy brain tissue we can spare going forward, probably the best for the patient in terms of their functional status, their interaction with their loved ones, and if they are on the tail of that curve and do very well and survive their cancer, we don't want their brain and their thinking and their functioning to be in the way of them leading their best life. As far as stereotactic radiosurgery is concerned, here's an example of a plan of an older individual with a RIN-enhancing lesion in the right cerebellum. You can see again all these different beams converging on this one spot to try to ablate or get rid of this. Nobody was going to go in and do surgery on this patient. Chemotherapy wasn't getting into the brain, but radiation does. And what you can see here is a scan approximately 6 months after his treatment. The spot that was once there in the corner is no longer present. What about radiation necrosis, another feared side effect of radiation therapy to the brain? This can be asymptomatic and quiet, or in some cases it can be symptomatic with associated swelling. Depending on where this is located in the brain, the patient may or may not have any neurologic dysfunction. The risk of radionecrosis increases with higher doses of radiation. The diagnosis of this can be challenging, as sometimes the appearance of this on imaging can mimic actual tumor progression. We try to use tools that we have at our disposal, including a special MRI sequence called perfusion that actually looks at blood flow to the area in question to see if it's hot or cold. Active cancer mainly trying to recruit new blood vessels, trying to take up blood and actually suggesting more cancer. If it's cold on the perfusion maps, thinking more along the lines of necrosis in a previously treated patient. How do we treat radionecrosis? Generally things like steroids, occasionally surgical resection if the spot in question is really causing functional problems. There's a medication called Avastin or bevacizumab, and a interventional therapy with our neurosurgeons called LIT, or laser interstitial thermal therapy, which can sometimes help to heat up that area and prevent the necrosis from causing symptoms. Just like the other organ systems we've spoken about, prevention and thinking ahead and limiting dose to healthy brain tissue is the best way to avoid this late side effect. Avoiding retreatment, having to give somebody a second course of radiation to the brain is important, as well as retreating the brain can increase the risk of necrosis by 20%. And in cases where cancers of the brain are larger, we tend to think about fractionating tumors, that is breaking up their radiation treatment into more than just a single treatment, sometimes breaking it up into as many as 3 or 5 sessions. A couple slides on proton therapy. Proton radiation reduces the dose to normal tissues by allowing for more precise dose delivery because of the unique physical properties of heavy particles. Proton therapy penetrates tissue to a variable depth, depends on the energy, and then deposits that energy in a tissue sharp peak. This peak is known as the Bragg peak, and you can see the Bragg peak here in this dotted line on this graph. The rapid dose fall off at depth beyond where the actual tumor is can be controlled by initial energy of protons. This allows for decreased radiation to adjacent normal tissues. The main advantage of this is that it can potentially reduce dose of radiation to critical structures that a cancer might be hiding in or next to. For many patients, this represents a unique opportunity to reduce late effects for patients who are receiving treatment. Proton therapy, while an amazing weapon to have in the fight against cancer, is not necessarily the right choice for every patient. It may not always be covered by insurance, and it may actually be unnecessary because patients may not have cancer so close to anything critical. Photon therapy may do the trick, and the dose in which it needs to do the trick actually is not so significant that a low dose of radiation next door to where you're treating would actually harm the patient. While promising, the data supporting its usage in the most common cancers is still emerging. At present, its clinical superiority, protons, compared with photons is clearly established in many pediatric populations and cancers. In rare situations where tumors are in close proximity to critical structures, in the case of, let's say, uveal melanoma, sarcomas of the base of skull, cases of re-irradiation, particularly in either spinal cord. This is where proton therapy shines. In other situations like prostate cancer, it is very effective, excellent therapy. It's being used increasingly, but the available data, randomized data, doesn't necessarily dictate its superiority over what we offer at most centers presently. Although protons have been evaluated in breast cancer, as well as other randomized trials in esophageal cancer, glioblastoma, lung cancer, many of which are now accrued and are waiting on results, protons haven't been established as clinically superior. And I say that for certain cancers because I don't want patients who are on the call thinking, oh, I should have done that, or why didn't I do that? It's not necessarily indicated for every single patient or every single kind of tumor. Trials are underway to determine the role of proton therapy in every cancer type, and we think looking forward, betting on the future, this holds a lot of promise for our patients, young and old, and with all kinds of tumor types. It holds so much promise that we've, at LCI, invested in building a proton center. And these are some schematic drawings. If you're familiar with the building in Boca, you see the main building and this extra unit, very architecturally interesting, just next door. If you haven't heard the news, we're building it. We're excited to be building the Proton Center right on the BRH campus, right next to where LCI is, adjacent to it, integrated with it, down the same hallway. And it promises to be both beautiful, state-of-the-art, and bringing an extra weapon in the fight against cancer to our community. That's world-class. The Proton Center is actively being built. And this is actually a snapshot of the live camera we have positioned on the Cancer Center looking at that build. This is from this morning. You know it's from this morning because the sun's shining, which it hasn't been doing for about a week now. But we're very excited by this, and you know, we're almost there. I do have a short video clip, if you'll allow me. I think it'll give some information about proton therapy, specifically pencil beam treatment delivery, and it'll give you a sense of how complex proton therapy actually is, and why the engineering behind it and the building behind it takes as long as it does.
Today, there are three main types of treatment to fight cancer: surgery, chemotherapy, and radiotherapy. Unlike traditional radiotherapy that uses photons to irradiate and kill tumor cells, proton therapy is an advanced form of treatment using protons. These particles give proton therapy its many advantages. Proton therapy's greatest advantage over conventional radiation therapy
Sorry about that.
is its accuracy and its ability to spare healthy tissues. Conventional X-rays are made of photons that pass through the body and deposit considerable energy before and after the tumor. Protons, however, have a particular physical property called the Bragg peak. They're able to deposit less energy on their way to the tumor and do not affect tissues beyond it. This property allows to confine the radiation dose to the tumor and radically decreases the risk of injury to surrounding healthy tissues. The proton originates from the ion source, where hydrogen atoms are separated into electrons and protons. The protons are injected into the cyclotron, where they're accelerated. Then, these high-power protons are sent through an energy selection system and a degrader that adjust their energy. The beam transport system conducts the protons with the right energy and trajectory. Then the proton beam arrives in the treatment room via a gantry. The gantry revolves 360 degrees around the patient so that the beam can be delivered at any angle. A high accuracy of patient positioning is required. IBA's treatment rooms are equipped with the latest patient positioners, alignment, and imaging systems to ensure the reproducibility of patient positioning. Today, proton therapy patients have access to a state-of-the-art delivery mode called pencil beam scanning. The beam is steered across the target volume one layer at a time, pixel by pixel, to precisely match the shape of the tumor. With this active scanning technique, the physicians are able to change the proton dose at any specific location in the target. This allows proton therapy to adapt to very complex shaped or moving tumors, improves the dose conformity, and reduces the integral dose of radiation given to the patient. Proton therapy is changing the way you treat cancer.
All right. So obviously, we're very excited by having this weapon at our disposal here in Boca. I will say that we do have access to it presently, though at our sister's cancer center down in Miami at MCI. We work collaboratively with them for select cases for patients that we feel would benefit from proton therapy. We have a very seamless process in which we can get patients treated down there as if they were being treated here in Boca. The only difference being obviously there's a bit of a commute, but fortunately within the next year or so, maybe coming months, we should be one step closer to being able to deliver this treatment to our patients locally, right in our backyards. As far as the talk, well, late side effects of radiation appear after a delay of months or years after treatment. Those side effects can depend on which tissue or part of the body is being irradiated, what amount of tissue is being irradiated, the dose of radiation administered, how it's being delivered in terms of technique, if other treatments are being given as well, chemotherapy, immunotherapy, either before, during, or after. as well as what individual patient risk factors are at play in somebody's potential risk of developing both acute and late effects. At the Lynn Cancer Institute, we utilize the latest technologies, techniques, and protocols to individualize treatment. The goal here is obviously minimizing the late effects of treatment. And I think we're very fortunate as a community-based cancer center to have world-class staff, world-class technology, and allow for our patients to get treatment closer to home so that they don't have to be displaced or fly or go somewhere else for their therapy. Since this is a survivorship lecture, and since a lot of what I spoke about is things that I do as a radiation oncologist to minimize late effects, what can patients do? How can they empower themselves as they're gearing up to undergo treatment, go through treatment, and then after treatment? I have a slide here just going over all the different supportive services that exist within the Lynn Cancer Institute, within our entire network, Boca, Delray, Boynton Beach. These services are available to patients during treatment, after, and all the time. They're free for patients, for family. I think what sets LCI apart is that we really take pride in treating the entire patient, mind and body. We want to make sure our patients, their families, they're cared for physically, mentally, spiritually, emotionally. We want them to feel informed, empowered. We want to deal with their issues. We want to deal with their side effects. We want to find ways to make this as smooth and easy as possible for them. We have a great social work team, support services team, and these are just some of the various things that we have at our disposal, that patients have at their disposal to really take advantage of during therapy. We have things related to support groups, fitness programs, wellness programs. There's even a massage therapist. I mean, we really have it all. And I feel like our community is very fortunate to have this center and all this programming available, because some centers do not. With that, I'll conclude, and I'll try to take any questions that the group has. Thank you.
Thank you, Dr. Richter. That was very amazing and very important information for all of us. You do have some questions. If you can't see them, I can read them to you. There's 2 in the Q&A and 1 in the chat box. Can you see them?
Sure. I see one patient said, I'll read it first. Are the machines at both the Miami Cancer Institute and are these machines at both the Miami Cancer Institute and Lynn Cancer Institute, or would a patient be referred to LCI if they have a more advanced machine? Great question. As we integrate even further between LCI and MCI, I think both cancer programs recognize that they have the same goals, they have the same want to treat the cancer patient as best they could. We have that they wanted to invest in technology to be the best, to be the leaders in the radiation field. I think that's why we're a good marriage. I can tell you that a lot of the machines, actually all of them now, really except for I think protons, we have here at LCI, and we're getting through the similar vendor that they have there, proton therapy within the coming months to years. Whereas we use CyberKnife to treat brain metastases, I know that they like using Gamma Knife. Essentially, both machines are effectively doing the same thing. We're happy to have them as well, because they have been pioneers in the MRI linear accelerator program, using that machine called the Meridian I showed you. And that has been a real extra benefit to us, as it's unlocked different ways to treat patients that we wouldn't have otherwise been able to. But we actually have that machine that they have down there right in Delray Beach, where I'm actually giving this talk from today. So a lot of the technology, a lot of the machines are the same, translatable. They can learn from us, we can learn from them, but that means for a patient that they don't necessarily have to schlep all the way down to South Miami for a particular treatment. Although there are some cases in which we might think that might benefit a patient. Certainly for now, if we had a patient who we thought proton therapy made sense, we would encourage them to make the trek. I do know that MCI, has a hotel right next to their facility. I have had patients stay Monday to Friday and come back home on the weekends. Hopefully in the near future, that won't need to happen because we'll have everything under one roof. But yes, there's definitely some synergy and some back and forth between our centers. I have another question. How can a patient stop or reverse bone loss years after treatment, specifically the jawbone and cervical spine? That's an excellent question. It really depends what the necessary reason for the bone loss is. Some patients come in more frail with lower bone density. In the case of some medication for patients with breast cancer, some of that may have to do with the endocrine therapy that they're on. For other patients, it may have to do with metastatic disease to the bones. But there are medications that can help bone turnover, remineralization, and strengthening of bones. A good question for my medical oncology colleagues, but there are therapies that can help with that. For cases that may be related to radiation, there are rare side effects such as insufficiency fractures, where somebody may have been treated when they were younger, and 20 years from now, the bone has been weakened as a result of all their therapy. That is sometimes a little bit more complicated. If that happens, the question becomes one of a surgical procedure. But overall, bone turnover, bone loss, maybe from years or in some cases decades of drug therapy, you kind of have to meet one drug with another drug. Yeah, I hope that answers that question. What is the most successful method for addressing radiation fibrosis in the neck? Like we spoke about, some of it, can be reversed. A lot of it sometimes settles in, and particularly the farther out from treatment you are, if fibrosis is still an issue, sometimes it can sometimes unfortunately be permanent. For patients with head and neck cancer, classically, that fibrosis is sometimes not reversible. We think of the woody neck. If you've ever known someone who's had that kind of treatment, there is medication for fibrosis. Vitamin E, pentoxiflin is one of them. Sometimes, exercise, stretching, physical therapy, depending on the nature and the location of the fibrosis, specifically for the skin or the neck. But it's not always a reversible process for a patient. I have another question. When will the proton machine at Lynn be ready for patients? I don't have that timeline in front of me, but as I showed you from that snapshot of what's going on actively this morning, this afternoon, they're building, assuming hurricane season keeps us on track. I believe we're scheduled, don't hold me to it, but I think it's happening early in 2026. So we don't have very long to go. I've had radiation 20 years ago at South Miami after a lumpectomy for DCIS. Should I be concerned about heart or lung damage? This patient had conventionally fractionated treatment over 5 weeks, which is very typical. Obviously, the longer out a patient is without having had any cardiac issues thus far, I think there's probably a very low risk that something's going to happen. At the same time, I think it's probably important, just given that you've done well for 20 years, which is amazing, probably good to check in with cardiology, because you were probably, younger when you were treated. You may or may not have a cardiologist already. I think some cardiac function testing, is probably indicated, just knowing your history, especially if it was a left-sided lung cancer. There's always the risk of secondary malignancies decades out from radiation therapy, but if you're doing well, I hope you'll continue to do so. Breast fibrosis sometimes recovers, sometimes more slowly. But in the case of another question was about breast fibrosis. In the case of both surgery and radiation, A lot of times there can even be scarring just from the surgery internally, right? Because that's often where the cancer is. We don't see it as much superficially, but that whole area can develop sort of a pocket of fluid or seroma, and oftentimes that seroma can be persistent. It can turn into more like a scar-like change on the inside of the breast. And then you add a radiation on top of that, and in that particular area or in that hemisphere or quadrant of the breast, you may always have some fibrosis. In other patients, some of whom may have more radiosensitivity, there can be more contraction of the breast, more fibrosis, more atrophy. Sometimes that's seen several years after treatment. Sometimes it's seen decades after treatment. And again, like we started with, we have to balance, the risk of cancer coming back, of needing a mastectomy, against, some of these later effects. So it's a delicate dance, but I would say the majority of women do very well, mostly asymptomatic from whatever fibrosis they do develop.
It's okay.
And yeah.
Wave to
Any other? Oh, we got another one. Um, 3 months. I had a question about fatigue. Excuse me, 4 years after treatment for both head and neck as well as breast radiation, and it sounds like both were given within about a 3-month time frame or very close in proximity. The question will be, excuse me, as far as chronic fatigue is concerned, why is that still going on? I think one thing that I would check in patients who have had radiation to the head and neck area are endocrine abnormalities. Often the thyroid gland is within the radiation field, and sometimes patients can develop hypothyroidism that can make them tired, but I don't have a great citation off the top of my head for reference, but it's important to get a workup for that fatigue.
Dr. Richter, can you see the chat box? Because there is a question in there.
Oh, I'm sorry. I was seeing Q&A, so I'll go to the.
Yeah, no, but there's both. People
Oh,
are.
sorry about that.
No, that's okay.
Okay, we talked about, I think, alluded to stress fractures and sufficiency fractures.
I'll
Thank you
just
so
say
much for some of the feedback. Let's see.
priceless
Glaucoma,
presentation.
glaucoma or glaucoma, not something I commonly see. I don't treat a lot of, excuse me, head and neck cancer, but cataractogenesis and development of cataracts or other ophthalmologic issues, can result from radiation, generally with higher doses where we're not being as protective of orbital structures or things like the lens, but generally, rare. I think we had the fatigue question, talked about fibrosis, seromas of the breast. If they're acute, sometimes it is best to drain them, especially if we're talking about partial breast treatment, in which we want a smaller target. Unfortunately, that's some of how some patients heal. Sometimes we do bigger lumpectomy cavities than we would do otherwise. Our surgeons, doing everything they can to preserve and save the breast. And sometimes those seromas can heal on their own, and sometimes they need to be drained. As far as back to the fatigue question and the hypothyroidism, and some patients may need supplemental medication to bring them back to within normal levels of thyroid function. Patients who have had radiation to the brain, obviously an endocrine workup, blood work would be one of those things I would recommend. That can either be done, by your primary doctor, or if you have a medical oncologist, or if you wanted to see a new medical oncologist, they would, be able to help you with that. If you're still in touch with the radiation oncologist who delivered your treatment, they might be a nice resource as well. They can look back and actually see exactly where they gave their treatment, and in doing so can can sort of tease out your symptoms and see if they make sense with respect to what was actually administered. I want to make sure I'm going back and forth between.
Yeah, I checked too. Oh no, I think
Yeah,
there's one more in the Q&A.
you're welcome.
There's one more in the Q&A. How are you on time, Dr. Richter?
I think we're okay.
Okay.
I have a patient who's discussing the fact that they had radiation for prostate. They have some what seems like now chronic irritation of the intestine or the colon. This patient needs to use a pretty routine bowel regimen to keep things regular. Sometimes the patients can get away with sort of over-the-counter medication, things like Miralax in one situation, Imodium in others, just to kind of get things into equilibrium. It's best to do that. I think if you're far enough out from your prostate radiotherapy and you're still having, bowel issues, rectal issues, issues with your bowel movements, it may be time to meet with a gastroenterologist. Perhaps, your treating radiation oncologist and that GI doctor can communicate. I know one of the things I do before a patient starts their radiotherapy is to actually, have a colonoscopy, just to make sure there isn't anything, at baseline that's a problem for them. And then it's important in future follow-up to look out for proctitis, to look out and make sure the colon's functioning properly, and it's just good health screening anyway. So particularly for a patient with prostate cancer, it's even more important.
Okay, that looks like it. Thank you,
All
Dr.
right.
Richter. This was so valuable. And I'll just say personally, thank you for that video on the protons.
Sure.
Because I know many people are seeing the inconvenience here at Lynn Cancer Institute. And when you see what's coming for the future, you can see
Absolutely.
that it's well worth it.
It's a
So
big
thank you for
investment.
sharing
and-
that.
Yep, big investment, and we're very excited by it. And so bear with us, and lots of amazing things to come at our center. Thank you, Jan.
And thank you everyone for all your questions. That was really awesome. And I want everyone to know that all of our lectures are recorded, and many of our past lectures are on our website. And for this lecture and the past few that we've had, but especially for today's, if you would like a copy of this lecture to even watch it again or share it with family and friends or other patients that you know would benefit, just send us a note, and Lee can send you the link to it. Probably next week it will be available. And Lee will also be sending out an evaluation, and we really appreciate your feedback. And not only the feedback, but we're able to then to get all your information, your contact information, so we can add you to our database. And let's see, our next presentation is going to be on Wednesday, July 24th, June 24th, for our nutrition presentation on the nutritional approach to managing irritable bowel syndrome, IBS. And that will be Katie, our clinical dietitian. So thank you, Dr. Richter. That was fantastic. And thank you for everyone that joined us today. And have a great weekend.